So we have a wonderful lineup, international, and what we'd really look to do is now take some of the talks we heard and sort of move it more to the global side. And maybe, Angelina, we'd start with you. You have a lot of experience. We've heard a lot of what's being done from the community perspective. What are we doing right, and what do we need to do better? A little bit about what you're doing.
Thank you so much, Jonathan. And I just wanted to start from a personal perspective because I was diagnosed 30 years ago, so that direction, the era that Sharon actually mentioned. So I've seen what has happened over the past 30 years. And so for me, I remember one time somebody asking me, what do you feel are your, hopes for the future in terms of treatment? And I said, I wish you could get to a point where we have 1 pill a day. But I was saying this years ago, never ever thinking that anything like that could happen in my lifetime. So to actually be talking about is actually wonderful. So what is being right, I feel, from particularly our setting, is that we actually have access to these innovations. In fact, in my personal perspective, from my personal experience, the process was really straightforward. It involved a couple of discussions with my consultant. I went away and thought about it, and then I started. And there's also really good communication between myself and my clinician. But then I go to a center of clinical excellence, so I would expect that as well. But I think what really needs improving in terms of even the patients within the UK, for instance, is we need more information, awareness, and clarification about these innovations. So I was at a Positive People's Conference a couple of months ago, and we did a session around treatment updates, and I shared my experience. And honestly, the number of questions that came up, and a lot of the people at the conference were advocates, treatment experience. So they really wanted to know the information. But I think the other thing that really needs to happen, and given the talks that we've just had, and particularly what has been mentioned, we need real equity of access. So I'll give you just a couple of examples from our setting. So I talked about mine, which was pretty straightforward. But then I also have a friend who started. For him, he had to literally self-advocate over and over for his clinician to say yes. And the other patient, the clinician was very supportive, happy to go with it, but then her clinic didn't have enough funds and it had to go to a case, So that's, we really need equity of access. I think one of the other things that is really important, and also given what we've just had, is flexibility in terms of the criteria. So I'm really happy to hear your talk, Monica, and to hear about the JAB study, whereby so that it can enable access to marginalized communities who sometimes people think just because maybe they may live a chaotic life, may not be able to adhere, but actually that is the community that really needs this access. And I think the other thing is having more women in studies, and I love to hear about Alana, and I think we need more and more of those. So just quickly, a couple more points, because I'm aware we have...
Take your time. Okay. Take your time.
So for me, what else is working? I love nurses and have absolutely nothing wrong to say about them. We know that more and more nurses are very engaged. And of course, giving injections, that's their bread and butter. So what we need is just more resources. And just finally, I wanted to also pick on some of what has been presented in terms of focusing on clinicians or doctors who actually have, take care of us in terms of giving us the new innovations. I think what's working well is more and more doctors are interested, more and more doctors want to work with it, but they don't have the resources, they don't have enough nurses to give the injections, etc. You know what it's like. Yeah. But I think in terms of what is working with clinicians as well, and I'll give the example of my experiences, the shared decision making between myself and my clinician is real shared decision making. So that's brilliant. But what can be improved? I think more resources, and I think the other thing that can be improved are attitudes. And I'm not saying all clinicians have these attitudes, but there are some clinicians, if you're being fair, that may not believe in the new innovations or may think they know better. So if I don't believe in them, I'm not actually going to recommend it to my patient. But other clinicians may make assumptions that because Jane is not adherent to treatment, I'm not even going to recommend it, but actually Jane is the very person who will benefit from it. Mm-hmm. So I think we need more information, even for clinicians as well, in terms of bringing them around the awareness to know that actually shared decision making is not what I decide as a clinician is actually what the patient wants. So I just wanted to end with a few other comments which I think are really important. So I feel that these new innovations, be they for prevention or for treatment, can be and are actually very life-changing. They can have life-changing impact for a lot of patients, and they already are doing that. But we definitely need the more information and awareness and the equity of access. But I think it's also really important to remember that we should not leave anybody behind. Because even if we get to a point whereby we have universal U equal U and we end the epidemic, there's still going to be very many people living with HIV out there, and we still need innovations that enable them to maintain their good quality of life and also live their best life. Because at the end of the day, these new innovations offer for me the 3 C's. They offer confidence, they offer confidentiality, convenience, there's 4 C's actually, and choice.
Wonderful. Thank you so much. Excellent points we'll continue to touch on. François, maybe now moving up to less rich countries, and specifically Africa. We see these great maps of all this access, and what's really happened in South Africa? What have we been doing, and what do we need to do?
Look, I think it's instructive when you hear rich countries, it's only a tiny fraction of probably 1% of people who need the drugs actually have access to them. And it's, when Monica talks about their immediate populations which need access to rilpivirine and cabotegravir, their immediate populations that need access to cabotegravir who just don't have access to them in the richest countries in the world, does talk to it. I mean, I don't really understand what was happening around cabotegravir, that everyone woke up, like almost designed these studies without expecting them to be successful. Like woke up, got results. We over 4.5 years since we had the first results through the door. They're talking about small amounts getting into the system in 2007 from generics. It's going to be a decade since we had the results that we're actually going to have widespread access to cabotegravir. If lenacapavir is successful, this is all going to be for nothing. So I do kind of get frustrated about these kind of, we do things sequentially rather than do them in parallel and plan for this. And I'm really hoping that we don't see this happening with lenacapavir. So certainly in the prevention world, again, I don't know why everyone's surprised, in the care manufacturing world, ViiV initially said we will produce enough, and they was surprised when more than a few thousand people actually wanted cabotegravir, for prevention. Then we get to treatment, and there's immediate need now for rilpivirine and cabotegravir, and complicated studies that need to be done to take this forward. And there's almost no drug in the system for rich countries, let alone for the large number of people in poorer countries that are going to require it. And the studies that are needed with these long-acting agents, which are not rilpivirine and cabotegravir, are not being pursued. So there's a huge development agenda that needs to be taken forward that's independent of the originator companies, that really needs to be put forward now and needs to be talked about seriously if people living with HIV are going to derive the treatment benefits from these very exciting agents. But if we leave it where things are at the moment, nothing's really going to get done until one of the companies comes up with a second. Chloe talked about the fact that we need 2 agents. Until one magically comes along in the same company and they're able to test them together, that's when we're going to finally get something that's going to be available to people with HIV.
Wonderful. So Ndivhuwo, I actually will go now to the community side. So, what are you seeing? You're actually very much involved actually in monitoring. Tell us a little bit of what's happening and what needs really to be done. I think François made some excellent points on the difference between the slide and what we're seeing actually.
So yes, from a monitoring perspective and from a community perspective, for someone who lives in rural Limpopo, you come this side and you hear that, hey, things are happening outside. And they're not necessarily reached home. And we welcome these innovations, but we feel that in South Africa, where we are currently, we still need to fix the broken healthcare system. We have so many people who get initiated on treatment, but disengage along the way due to the broken public healthcare system that we have. We have people getting to facilities and waiting for over 6 hours to be able to access mere treatment. So yes, we welcome innovations, but we still feel that as a country as South Africa, there's much more that we would need to fix, even in terms of staff attitudes as well. Noting that South Africa also is lagging behind in terms of ARV refill lengths. We still have a majority of people who we are monitoring, about 37% of people living with HIV still receiving a 2-month ARV refill length. and we are talking about bigger innovations, and we're finding that in our communities, we are still struggling with a simple 6-month refill at the moment. Also, in terms of collecting that treatment, collecting those refills is also takes a very long time. When I'm going to collect treatment, I still have to pull out a file. They must take out my vitals. It's not as easy or as simple as it should be. And this is not just for people living with HIV only, but these challenges that key populations are also facing in terms of that. We also have high levels of stock outs that we still need to work on and deal with. So our innovations also need to consider these contextual issues that we are also facing in our countries as well. When we look at issues around PrEP and lube, you might think that lube is a simple thing, just for HIV prevention. It's still a challenge across the facilities that we monitor, where a majority of facilities will tell you that, yeah, no, we do offer lubricant, but only to find that it's available upon request, or it's placed in an area where everyone can see me picking it up, or I'm shouted at for taking as much as I need. Put it back. So there are also those kinds of issues that also we need to pay attention to, especially if we are going to want to innovate in the ways that we want to innovate in. So there's also just this need to really fix these simple issues, and they're quite simple before we can, go even bigger and better in restoring the dignity of people living with HIV in South Africa. When we look at issues of PrEP and PrEP uptake, a lot of facility managers who we speak to will tell you that we do have PrEP available, but when you go on the ground, when you speak to key populations, they will indicate that I've never been offered this PrEP. What are you talking about? So there's issues around educating people, being on the ground and teaching people what PrEP is, the availability of PrEP, and telling facility managers and OPMs to offer PrEP to everyone who comes into the facilities, and also trying to break down our rural-urban divide. When we look at issues of pickup points in picking up, external pickup points specifically, in urban areas they work very well, but in rural areas it's very hard to find an external pickup point where you can go and find your treatment. So it's the simple innovations that we are still struggling at the moment. And yes, we do appreciate the innovations that are coming out. And maybe community-led monitoring is another innovation that's going to work for us in terms of seeking social accountability as a mechanism in ensuring what do the communities want and what do communities need, what is working for communities and what is not working at the current moment. So I think I'll end there for now. Yes, we welcome the innovations, but yes, still, we need to fix our healthcare systems because he who knows it feels it.
Thank you so much. Excellent points. Monica, you're based in San Francisco, but you do a lot of international work and are looking at some of these. So what are some of your take-home points for what we've discussed, and what do we have to do differently? And I'll have some more questions, but I wanted your sort of overall thoughts on all this.
Yeah, well, what is hitting me right now is that in 2000 in Durban, there was oral ART at the International AIDS meeting. There was oral ART available for the US and Europe, and there was hardly any oral ART available for where the 2/3 of the epidemic lay was East and Southern Africa. And there were huge protests. Like everyone at this meeting were out protesting, saying, I'm not going to take my HIV medication if I can't, my brothers and sisters in South Africa cannot get HIV medication. And it was part of what we did, because that's what HIV activists and community and advocates and clinicians and researchers do. They think about social justice and injustice. And what it feels like to me now is that all we talk about at these HIV meetings, when you really go into the ART sessions, is long-acting, because we're so excited about it. And we're so excited about long-acting PrEP, and let's just say, like, the biggest, it's going to be really crowded, the Purpose One trial presentation, everyone's very excited about it. It's all the, the press release looks like lenacapavir, at least so far, has 100% efficacy. I think there's going to be some infections, but it's still, it's very exciting. And yet you're talking about all this excitement, and we're still in that place where if any access is to be had, it's in high-income countries, and it's not even as high as I thought it would be at all 4 years into it. It's 1.4% of all PrEP prescriptions in the U.S., as Jürgen showed, was cabotegravir PrEP, and cabotegravir rilpivirine is higher than that, but not that much. And so, but it's not here at all. It's not in sub-Saharan Africa at all. I mean, it's in the CARES trial, and then we don't even have guaranteed access to Cabril after the CARES trial goes past its 96-week point. I mean, that is not where it's feeling like that 2000 in a different way, where you can talk about how excited you are, but we don't have that access. And so it's not feeling fair, and it's feeling, and I think it's really complex, and it has to do with somewhat the pharmaceutical pricing, not working with the medicines patent pool effectively, because that's what the medicines patent pool is supposed to do, is supposed to allow generic companies to make it, maybe requiring too long of bioequivalence PK data by the WHO to show that cabotegravir is equivalent. That's just going to take too long. And also one company worrying that the other company may usurp them because lenacapavir can look good. There's lots of reasons that we're not where we need to be, but we should be protesting. we should be talking out about this, because I will tell you that because I've been lucky enough to be able to get these medications for my patients who have substance use, homelessness, mental health concerns, lots of competing priorities, they really like them. They really like them. It really works. There are times where they have never been virologically suppressed, and their CD4 count went from 50 to 200, and suddenly I'm not worried about them anymore. They were in and out of the hospital. Like, I can tell you as someone who's had experience that these work really well for adherence challenge patients. So the access is what we need to talk about, and it can't be lip service. You can't put out something where you say, we recognize as a company we need access. We need really specifics about how that access is going to be. And this has to come from all of us, clinicians, researchers, advocates, patients, NGOs, because that's how we made it change with oral ART in the 2000s.
That's a great point. So maybe focusing on access. Maybe, François, you want to start also? I mean, what do we need to do on that?
I mean, I think we do need to it is a collective effort. I mean, I'd always say, we could have lenacapavir or cabotegravir released into South Africa tomorrow, and the health system is not going to be able to absorb it. It's the first step. We don't have anything to test at the moment to test the healthcare system, and these innovations by themselves are not going to change things. They are potentially transformative, but there's a whole lot of work that needs to be done around them. The whole process of bringing them to a health system revolves around guideline change, around supply lines, making sure that the healthcare workforce is trained. So it takes a village. It really does. So we do need all the smart people in the room and everybody who knows how the system works, including the community, to be part of that project. Yes. But the starting point does need to be understanding that the drug is available at a price that can be accommodated by the health system that's being introduced. And that, unfortunately, is the point we're sitting at the moment, is we don't know how to get access to it. And that access point, I think, for all of us is turning into a major frustration.
Ndivhuwo, any thoughts on that?
I think François has pretty much covered it. That's exactly what it means. It means having the system ready for the innovations to come in the onset. Sometimes we need right now innovations, which to say let's give people living with HIV their 3 to 6 months refill while we are fixing the healthcare system, while we're working together with the National Department of Health to update the guidelines and be prepared for the innovations as they come. We can see them, but let's prepare ourselves as a country as well.
Wonderful. Angelina, final comments. We're coming close to the time. We'd like to hear your thoughts.
Thank you very much. So everybody has said everything is a collaborative effort, and all key players need to be at the table to advocate for the medication. But I think we need to go further to also ensure that patients have treatment literacy to understand all the innovations. And finally, what I think we need to do is also to have interventions that address the different types of stigmas, the self, the societal, and the ones patients experience in services. Because just because a treatment is available doesn't mean that a patient is going to take it.
Monica, do you want to have a
Well,
final?
just, I mean,
Sure,
one
we have
final
time.
thing, we just had a pandemic and we didn't have global equity in vaccines, and the WHO is trying to put together a pandemic treaty, and people aren't signing on, that says we need global access in the next pandemic for treatments, vaccines, and testing. This global access is terribly important, or things will continue. And the projection that's happening at this meeting is, if we let things continue, as the UNH just reported on the statistics, by 2030, we will have lost so much ground. We can't let it continue. We can't talk about all these hopeful things without making them accessible. So we have to hold people accountable to that.
Hear, 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 hear.